Hello friend, today we will discuss rheumatoid arthritis from Davidson. So rheumatoid arthritis is inflammatory arthritis, chronic inflammatory arthritis. So it is the pathophysiology having some genetic predisposition and environmental predisposition. So from the picture we can see there are some environmental predisposition trigger factor like smoking and infection, and genetic predisposition like HLA, DR4 association, and some other immune response are responsible. So they trigger dendritic cell, then they activate a T cell, then T cell activated T cell secretes tumor necrosis factor alpha and interferon gamma. They stimulate macrophage, and macrophage also stimulate synovial membrane, synovial fibroblast. They secrete some cytokine like interleukin 1, interleukin 6, and tumor necrosis factor alpha. And this factor now again stimulate the macrophage. So there is inflammation in the synovial cartilage. So there is bony destruction. So this is the primary stage of involvement of joint. This is the pathophysiology during acute phase. So as per European League Against Rheumatism or American College of Rheumatology 2010, there is a diagnostic criteria for diagnosis of rheumatoid arthritis, where you can see number of the joints involved, serology, duration, and acute phase reactant. 1 large joint 0, 2 to 10 large joint 1, 1 to 3 small joint 2, 4 to 10 3, and more than 10 joint including one small joint 5 point. Negative are rheumatoid factor and ANCA 0, low titer rheumatoid factor or ANCA 2, high titer of rheumatoid factor and ANCA score 3, duration less than 6 weeks score 0, more than 6 weeks score 1, normal CRP-ESR score 0, abnormal CRP-ESR 1. So more than 6 point is considered to have definite rheumatoid arthritis. So what are the clinical features? Clinical features is actually arthritis, that is the pain and joint swelling and stiffness of the especially the hand joints. This is symmetrically in fashion. There are some there may be some large joint. Systemic symptoms may be present and morning stiffness is there. So the presentation may be acute presentation with early morning stiffness, polyarthritis, and pitting edema. On the other hand, another presentation is proximal muscle stiffness, which mimic polymyalgia rheumatica. Another presentation is palindromic, where there is relapsing and remitting episode of arthritis. So if along with arthritis, if there is erythema in the joint, that suggests coexistent in sepsis. So there will be some deformity in the joint. Along the deformity, there may be swan neck deformity, jet buttonhole G deformity, jet form deformity of the thumb, dorsal subluxation of the ulna, radio-ulnar joint subluxation, atlantaxial subluxation. So there are many types of subluxation. Joint dislocations are present. So ultimately that gives rise to joint deformity. There may be association of loss of longitudinal arch, flat foot, and a rupture of the posterior tibialis tendon. Popliteal Becker cyst may occur in case of chronic knee synovitis. So where rupture may be induced by knee flexion, leading to calf pain and swelling, and mimic a deep vein thrombosis. So the rupture of the Becker cyst may mimic deep vein thrombosis of lower limb. There is some associated systemic symptoms. Along in the systemic symptoms, anorexia, weight loss, fatigue is common. There is systemic muscle wasting. There are some extraarticular features. There is a box of extraarticular presentation. In the box, there are some extraarticular presentation of rheumatoid arthritis. Like in systemic features, the patient may have fever, weight loss, fatigue, susceptibility infection. In the musculoskeletal system, there may be muscle wasting, tenosynovitis, bursitis, osteoporosis. In hematological system, there may be anemia, eosinophilia, and thrombocytosis. If the advanced rheumatoid arthritis, that may be associated with Felty syndrome, that is a patient with advanced rheumatoid arthritis with splenomegaly, lymphadenopathy, pancytopenia, and infection. So there may be lymphadenopathy and splenomegaly. Persistent lymphadenopathy may result in lymphoma. There may be skin nodule, sinus and fistula. There in the eye there may be episcleritis, scleritis, keratomalacia, keratoconjunctivitis, Zika, dry eye. In the skin there may be vasculitis, ulcer, pyoderma gangrenosum. Neurology, there may be peripheral neuropathy, mononeuritis multiplex, visceral arthritis. In the heart there may be carditis, myocarditis, pericarditis, endocarditis, conduction defect, coronary vasculitis, granulomatous aortitis. In the lung there may be pulmonary nodule, effusion, bronchiolitis, and Kaplan syndrome. That is the lung nodule in the lung. In the neurology, there may be cervical cord compression due to atlantic cell subluxation and bony fracture. There may be compression or entrapment neuropathy. There may be peripheral neuropathy and mononeuritis multiplex. Long-standing rheumatoid arthritis may result in amyloidosis, proteinuria, or intractable diarrhea, or nephropathy or nephrotic syndrome. So there is a chart in the Davidson about investigation and monitoring of rheumatoid arthritis. For diagnosis, we follow the diagnostic criteria of American College of Rheumatology. So patient having systemic symmetrical polyarthritis involving small joints of the hands. There will be involvement of the metacarpophalangeal joint and PIP joint. There will be duration will be more than 6 weeks. There will be morning stiffness. Pain is inflammatory in nature. There may be raised ESR or C-reactive protein. There may be raised rheumatoid factor or anti-CCP antibody. There will be imaging evidence of rheumatoid arthritis. That is the bony destruction, periarticular osteoporosis, synovitis. So for monitoring of the disease activity, we follow for pain visual analog scale to this patient. Then we check the morning stiffness, joints, number of the joint swelling, number of joint tenderness, number of joint for tenderness, number of joint for swelling. Then we check in a computer and a calculator for DAS28 score. Then we also check ESR and C-reactive protein for disease activity. To monitor the joint damage, we assess functional assessment and X-ray. And for drug safety, we check full blood count, liver function, kidney function, urine analysis, and chest X-ray for monitoring of the drugs safety. So in the management, the aim of the treatment to suppress inflammation, control symptoms, and prevent joint damage. This involves combination of pharmacological and non-pharmacological therapies. So among the pharmacological therapy, DMRD is most important. So in the early stage, there may be initiation of NSAID and steroid that should be started 30 mg daily, and that will be tapered over 12 weeks. That should be tapered over 12 weeks. Similarly, we should start DMRD like methotrexate, that should be optimized over 12 weeks. So to counter this side effect, we have to give folic acid, PPI, proton pump inhibitor, and calcium and vitamin D supplementation. So this is the calculation of disease activity. Thus, we have to calculate, count the swollen joints, tender joints, measure ESR, note patient global health assessment, and we have to insert all the information to the calculator. So newly diagnosed rheumatoid arthritis, we should start methotrexate and prednisolone. Prednisolone should be tapered over 12 weeks, and methotrexate should be optimized over 12 weeks. After 12 weeks, the disease activity should be monitored, and if the DAS score is less than 2.6, then a patient is in remission. If it is more than 2.6, then a patient is not in remission. So if he in remission, continue the methotrexate. If the patient is not remission, we should add another DMRD like sulfagenazine or hydroxychloroquine or leflunomide. If this disease again 6 weeks, then if the disease activity is more than 5.1, we have to add biologics. If it is between 2.6 to 5.1, then we have to add low dose steroid or change the DMRD. If it is less than 2.6, then we have to continue the triple therapy. So this is how the treatment should be continued. So more in the non-pharmacological therapy, we should have regular physiotherapy, exercise, and nutrition should be maintained. There may be requirement of surgery, especially in case of atlantaxial subluxation for new onset headache, occipital headache. We have to check, is there any chance of atlantaxial subluxation or sudden death. If there is any chance, we have to send the patient for neurosurgery for fixation of that joint. So this is all from Davidson. So another chart, how we will treat a patient of rheumatoid arthritis in pregnancy. In pregnancy, the patient should be in remission, and conception should be delayed until the patient is in remission. So methotrexate should be stopped at least 3 months. Leflunomide should be discontinued at least 18 to 24 months before conception. Paracetamol can be continued throughout pregnancy, but NSAID should not be continued beyond 6 months of pregnancy. So steroid can be continued in low dose throughout the pregnancy, but there is risk of maternal hypertension, maternal diabetes, glucose intolerance, and osteoporosis. It should be taken into mind. DMRB should be continued, especially salagine, hydroxychloroquine, and azathioprine. The methotrexate, leflunomide, cyclophosphamide, and phygomycophenolate mofetil should not be continued. Biologics, this can be limited. During breastfeeding, methotrexate, leflunomide, cyclophosphamide are contraindicated. So this is all from Davidson. Now I'll discuss a long case of rheumatoid arthritis. Usually rheumatoid arthritis, a patient of rheumatoid arthritis presents with arthritis, that is the joint pain. Patients present with joint pain. So pain and swelling of multiple joint is for a longer duration of period is the presentation. So the chief complaints from the situation scenario, we have some differences like patient may be case of rheumatoid arthritis, systemic lupus erythematosus, psoriatic arthritis. So in the history we should take relevant information among the for the diagnosis, for the provisional diagnosis, and for the differential diagnosis to be excluded. So when a patient presents with polyarthritis, we should have bear some cause for the polyarthritis. The common causes of polyarthritis is rheumatoid arthritis, systemic lupus erythematosus, viral arthritis, seronegative like psoriasis, reactive ankylosing spondylitis, enteropathic arthropathy, generalized osteoarthritis, chronic gout, juvenile idiopathic arthritis. So these are the causes of chronic polyarthritis. And when patient presents with symmetrical polyarthritis, then the rheumatoid arthritis, viral arthritis, systemic lupus erythematosus, generalized osteoarthritis, and juvenile idiopathic arthritis becomes the differentials. So common presentation of rheumatoid arthritis, they present with symmetrical polyarthritis, follows relapse and remission. They present with some extra-articular presentation. They may present with oligoarthritis. They may present with acute arthritis with constitutional features. The patient may present with monoarticular attacks lasting for 24 to 48 hours. So, based on the presentation, we have to examine the patient. We have to examine all the joints of the patient. We have to check the hands, feet, skin changes, muscle wasting, deformity, tenderness. So which joints are affected? We have to check cardiovascular system for pericarditis by pericardial rub, abdominal examination. Is there any abdominal tenderness present or not? Is there any splenomegaly present or not for Felty syndrome? We have to examine the chest for evidence of pleurisy, pleural effusion, or interstitial lung disease. We have to check the nervous system for look for peripheral neuropathy, carpal tunnel syndrome, or cervical cord compression. So after the salient features, there will be some question. So I am discussing some question of long case of rheumatoid arthritis. So there will be question, why do you consider the diagnosis? Then we have to answer like that the patient is a middle-aged female. This patient has pain and swelling in multiple joints which are symmetrical, with have morning stiffness more than 30 minutes or 1 hour. Their duration was more than 6 months. So that should be firstly mentioned. Then we have to mention that patient have polyarthritis involving PIP and metacarpophalangeal joint, wrist joint, and tarsal joint, both knee or elbow joint. That should be mentioned. We have to mention that patient has some deformity like jet form deformity, swan neck deformity. So patient has deformity, we have to mention that one. Then we have to mention, is there any extra-articular presentation, extra-articular features are associated with the arthritis. That should be mentioned. And then we have to stand for the diagnosis of rheumatoid arthritis. Then there will be question, why it is not SLE. So patient, we have to answer that patient has deformities. Is usually in SLE there will be non-deforming arthritis, and there should be presence of rash, photosensitivity, alopecia, or oral ulcer. These are absent, so it is not SLE. So there may be a question, why it is not a generalized osteoarthritis. So most important is that the age osteoarthritis commonly occurs in above the age of 50 years. So patient is young, so it is not generalized osteoarthritis. Then in case of osteoarthritis, pain is mechanical in nature. That is, the activity increases the pain. But in case of rheumatoid arthritis, pain is inflammatory in nature. But rheumatoid arthritis may be associated with generalized osteoarthritis. So Haberdas note or Boucher's note are usually present with the osteoarthritis. These are absent in case of rheumatoid arthritis. Why this is not a case of psoriatic arthropathy? There is no present history or family history of psoriatic skin rash. So that is the very important diagnostic exclusion. And psoriasis usually involves distal interphalangeal joint. And there may be skin rash and nail change. So absence of this support the diagnosis of rheumatoid arthritis? There may be a question, may arthritis precede the development of ciliated skin rash? Yes, arthritis may develop before skin rash. What are the diagnostic criteria of rheumatoid arthritis? So we have to tell the diagnostic criteria of American College of Rheumatology 2010. So this is the diagnostic criteria of rheumatoid arthritis: joint involvement, serology, acute phase direct, and duration. So what are the ocular presentation of rheumatoid arthritis? Episcleritis, scleritis, keratomegaly, and keratoconjunctivitis sicca. Episcleritis is not painful, scleritis is painful. How you can differentiate episcleritis and scleritis? Episcleritis is not painful, scleritis is painful. What are the cardiac manifestation of rheumatoid arthritis? Pericarditis, myocarditis, endocarditis, conduction defect, coronary vasculitis, granulomatous aortitis. Neurological manifestation: cervical cord compression, compression neuropathy, entrapment neuropathy, peripheral neuropathy, mononeuritis multiplex. Pulmonary manifestation: pulmonary nodule effusion, Kaplan syndrome, fibrosing alveolitis. These are, what is Kaplan syndrome? It is the co-worker pneumoconiosis with rheumatoid nodule in the lung. Co-workers pneumoconiosis with rheumatoid nodule in the lung. What is Felty syndrome? It is the advanced rheumatoid arthritis associated with splenomegaly and pancytopenia. May be associated with lymphadenopathy. Why does muscle wasting occur in rheumatoid arthritis? Due to cytokine, prolonged disuse, and nerve entrapment. What are the joints commonly involved in rheumatoid arthritis? Almost all the joints except distal interphalangeal joint and first carpometacarpal joint. First carpometacarpal joint and distal interphalangeal joint and lumbosacral spine. How many joint areas are included in the diagnostic criteria? So there are 28 joints, 14 joints in each hand. So total 28 joint. So how would you investigate? We have to investigate by ESR-CRP, RF anti-CCP, ANA anti-DS-DNA, then X-ray, MRI, then CBC, liver function, kidney function, urinary. Anti-CCP are highly specific for rheumatoid arthritis, may be present 10 years before development of rheumatoid arthritis. What is rheumatoid factor? It is the antibody reaction FC portion of IgG. It may be IgM and IgG type. It is positive is 70% of the cases. Rheumatoid factor is an IgM antibody which reactively against the FC portion of the IgG. So it is an IgM antibody but works against the FC portion of IgG. Why there is anemia? There is usually normochromic normocytic anemia, but there may be hemolytic anemia due to Coombs test may be positive. There may be bone marrow suppression in Felty syndrome, or there may be pancytopenia in splenomegaly. There may be hypochromic microcytic anemia due to NSAIDs. There may be macrocytic anemia due to folate depletion in methotrexate therapy. What are the radiological features in rheumatoid arthritis? Soft tissue swelling, periarticular osteopenia, marginal non-proliferative erosion. Proliferative erosion occurs in psoriasis. Reduction of joint stress, subluxation of and bony ankylosis in advanced stage. Periarticular osteoporosis and osteopenia would indicate the diagnosis of rheumatoid arthritis. Loss of joint space may occur in osteoarthritis, also in pseudogout. What are the principles of management? Pain relief, reduction of inflammation, protection of articular structure, maintenance of function, control of systemic involvement. Management: non-pharmacological, education, exercise, physical treatment, physiotherapy, hydrotherapy, joint splitting. Pharmacological therapy: NSAID, steroid, DMRD, biologics. So what are the indications of DMRD therapy? Persistent inflammation more than 6 weeks, systemic vasculitis, systemic lupus erythematosus, cardiac, renal, and CNS involvement, and adjunct to steroid therapy. What are the side effects of methotrexate? Hepatitis, myelosuppression, pneumonitis, pulmonary fibrosis, mucositis. So, how we will monitor the function of methotrexate? CBC, liver function, kidney function, initially 6 weeks, and after stabilization, every 3 months, then 6 monthly. Side effect of sulfasalazine: hypersensitivity, myelosuppression, macrocytosis, reversible azoospermia in smell, orange staining of urine, and contact lens. So, sulfasalazine causes hypersensitivity, myelosuppression, macrocytosis, reversible azoospermia in smell. Indication of the steroid in rheumatoid arthritis: short-term control of inflammation, maintenance therapy, and systemic vasculitis, chronic inflammatory disease during pregnancy. Disease control during pregnancy. Indication of intra-articular steroid: it is better to avoid multiple injections on the word-bearing joint, but it may be given. What are the biologics? Anti-TNF agents: infliximab, etanercept, adalimumab. Interleukin-1 receptor antagonist: anakinra, rituximab, abatacept, and tocilizumab. How you will assess the response to therapy? Reduction of joint swelling and pain, reduction of joint stiffness, reduction of joint tenderness, decrease ESR, decrease CRP. What is DAS-28 score and its use? DAS-28 score is disease activity score used to assess disease activity, response to treatment, and need for biologic therapy. If rheumatoid arthritis is untreated, then what would be the complication? Joint destruction, deformity, disability. Complication of rheumatoid arthritis: in the joint there may be ruptured tendon, ruptured Becker cyst, joint infection, cord compression, amyloidosis, dysphagia, GI bleeding due to therapy, perforation, anemia, renal impairment, bone marrow hypoplasia. What are the poor prognostic factors for rheumatoid arthritis? Insidious onset, higher baseline disability, female gender, involvement of metatarsophalangeal joint, positive very high titer of rheumatoid factor, high ESR, high CRP, duration more than 3 months without treatment. What are the prognosis of rheumatoid arthritis? Lifespan reduced by 8 to 15 years. 40% will be disabled within 3 years. 80% will be disabled within 10 years. If no treatment, 20% complete remission. There are some virus causes arthritis like rubella, hepatitis B, parvovirus can cause arthritis. So this is from a long case presentation.